So today we are looking at thyroid hormones as regulators of whole body metabolism. And a useful way to think about the thyroid hormones is that they set the metabolic pace of the body. And so if there's too little thyroid hormone, that'll slow many systems down, while too much thyroid hormone increases that metabolic activity. And therefore, too little or too much will have large influences on what's happening in the body. So at the end of the session, we want you to have a kind of an idea of what's going on today. We want you to think about the hypothalamic-pituitary-thyroid axis. So what hormones are regulating what processes to allow for thyroid hormone to be released. And then we'll think about what the major physiological effects of the thyroid hormones actually are. So when we're thinking about the thyroid gland itself, it weighs about 15 grams, and it's connected by two lobes, or the two lobes are connected by isthmus, which is just a band of connective tissue. The thyroid hormones that the thyroid gland secretes, those are T4 and T3. They are known as thyroid hormones. They are amine hormones, and they are derived from tyrosine amino acid and from iodines. And when they're being made, in particular T4, because T4 is what is mainly produced by the thyroid gland, whereas smaller amounts of T3 are made, the fundamental difference between them is that T4 has a tyrosine with 4 iodines attached, and T3 is a tyrosine with 3 iodines. But remember, it's the T3 that is much more biologically active than T4. And so most of the circulating T3, because it's not being made in the thyroid gland, it's produced from T4 in peripheral tissues. And this is really actually quite clinically important, because when you give patients thyroxine or levothyroxine, which is basically synthetic T4, that synthetic T4 can then get converted to T3 in the peripheral tissues at the levels that they actually need. So it's a good, nice way of a kind of understanding what's happening in the body. So let's have a think about what the main functions of the thyroid hormones actually are. So they influence the metabolic rate. So the thyroid hormones increase metabolic rate in many, many tissues. They increase fuel mobilization and utilization. So therefore, cells turn over carbohydrates, lipids, and proteins at a higher rate. And in doing that, they also increase heat production. And that helps to explain why hypothyroid patients might feel cold and hyperthyroid patients might feel hot. You've also got the cardiovascular functions. So they increase the responsiveness to the catecholamines. So the catecholamines are basically things like adrenaline and noradrenaline. And because they're increasing the receptor responsiveness, it means you can have a normal level of adrenaline and noradrenaline, but they produce a greater effect. And so that, again, is why a hyperthyroid patient may look like they're in a state of sympathetic overactivity with tachycardia, so higher heart rate, a tremor, and heart palpitations. We then go on to growth and development, and these developmental effects are particularly important in fetal life and infancy. And thyroid hormone is essential for normal brain development, growth, and skeletal maturation. It also, in doing this, in that growth and skeletal maturation, is promoting the effects of growth hormone and the insulin-like growth factors. And it's growth hormone that drives the synthesis of the insulin-like growth factors from the liver. And finally, thinking about the GI, it increases GI motility and secretion. So again, you can start thinking what might happen in patients who are hyperthyroid or hypothyroid. Increased GI motility, reduced GI motility. So what we're going to do now is we're going to have a little bit of a think how thyroid hormone release is actually regulated. So in response to a reduced metabolic rate, or cold in infants in particular, the hypothalamus releases thyrotrophin-releasing hormone, or TRH. TRH then goes down through portal blood vessels to the anterior pituitary, where it stimulates the release of TSH, thyroid-stimulating hormone. TSH goes to the thyroid gland, acts on the thyroid, what are called follicular cells, and it stimulates iodide uptake into those cells. It stimulates thyroid hormone synthesis, and it stimulates thyroid hormone release. And so you're getting the release, like we said, in particular of T4, and lesser amounts of T3. And as those circulating T4 and T3 levels rise, they suppress TSH and TRH levels. So you're starting to get this negative feedback loop occurring. And as well as suppressing TSH and TRH and therefore regulating their own levels, they are having their effects in those metabolic tissues. So metabolic rate, heat production, growth, CNS development, all those things that we talked about in that last slide. But something that's also really important to think about is that stress and acute illnesses can suppress aspects of the hypothalamic-pituitary-thyroid axis, which becomes relevant later when you start to interpret thyroid function tests in unwell patients. You can't properly predict what someone's thyroid function is if they are acutely unwell by looking at TFTs or thyroid function test results. So what we're going to do now is just have a little quick questions just to see that you're all on track with what we've just covered, which has been thinking about the feedback loops in thyroid hormone production and what is stimulating what. So I'd just like you to look at the two questions. Think about what you think the answers may be. So there may be more than one correct answer, correct in some of these. Yeah, so press pause and then we'll go through it. Okay, so hopefully you've had a good bit of a think about this. So we'll just do the first one to start with. In the process of negative feedback, which of the following that are in front of you are true? I'll give you a clue. Hopefully you only picked one of them as being correct. And if you only picked one of them being as correct, hopefully you picked number 2. So thyroid hormones inhibits TSH secretion by the anterior pituitary. None of the others are correct. Okay, so let's do question number 2. Which statements are true about thyroid hormones? So again, hopefully, in this case, you've picked more than one. 3 of them are correct. So let's rattle through the correct ones. So number 1, that is correct. T3 is the most active thyroid hormone. It is converted from T4 peripherally, and it is the most active form. Iodide for thyroid hormone synthesis is taken up by active transport into the thyroid gland. Yes, it is. We didn't actually cover that, but yes, it is taken up by active transport. Thyroid hormones are transported in the blood in protein-bound and free forms. Yes, that is also correct. So the thyroid hormones, they are lipophilic. So they are fat-liking. So therefore, just like steroid hormones, which are made from cholesterol and from fat-soluble drugs, they need to be carried bound to proteins, okay? And so the majority of it is protein-bound, and then the free form is just that little bit that's free floating around. That is the bit that can enter the tissues and have the effect that it's going to have. Okay, thyroid hormone's release is stimulated by TRH. That's not correct, or not directly at least, because thyroid hormone release is stimulated by TSH. TRH acts on the anterior pituitary to stimulate TSH. TSH acts on the thyroid gland to release thyroid hormones. Okay, so what we're going to do is have a little bit of a think about abnormalities of thyroid function now. So really, we've done everything we need to do on thyroxine, thyroid gland, the thyroid gland itself, and thyroid hormone production. We're thinking about what happens in thyroid disease. Well, euthyroid just means normal thyroid function. That's all it means. Hypothyroid means insufficient thyroid hormone action. So in general, things like the metabolic rate goes down and patients may gain weight. And hyperthyroid, the opposite, of course, you have an excess thyroid hormone production, and in general, metabolic rate starts to increase and weight loss will also likely occur. Clinically, you may also hear, or you might hear the term thyrotoxicosis. That just refers to the clinical state caused by excess thyroid hormone, regardless of whether the source is specific diseases, such as, we'll come to it later, but Graves' disease or thyroiditis, or if it's excessive replacement therapy. So if you hear the term thyrotoxicosis, it's just the clinical state caused by excess thyroid hormone. So this table is kind of about localization. And what I want you to do is kind of predict. You've got a set of thyroid function tests in front of you now, and you're going to tell me whether you're free T4. So when we say free, that's the kind of the stuff that's floating around the blood that is not bound to protein. Okay, so free T4 or free T3. So it's not bound to protein. So we want to know what the levels of T4, TSH, and TRH would be, whether they are high, low, or normal, if we have primary hypothyroidism, so that's due to an issue with the thyroid gland, whether it's secondary hypothyroidism due to an issue with the pituitary gland, or if it's secondary hypothyroidism due to the hypothalamic issue causing that hypothyroidism. So all I want in each case is just high, low, or normal. So again, we're going to do primary, then secondary pituitary issue, and then secondary hypothalamic issue. So I just press pause, and I just want you to complete the table, please. Okay, so let's go. Primary hypothyroidism. So in primary hypothyroidism, the issue is with the thyroid gland itself. It's hypothyroid, so obviously the free T4 is low. TSH is coming from the pituitary, and because T4 is low, there isn't as much feedback going to the pituitary, so therefore the TSH rises, and likewise the TRH rises as well. So in primary hypothyroidism, the thyroid gland is failing, so thyroid hormone falls, and the pituitary responds by increasing TSH, and the hypothalamus also increases TRH. Now, in pituitary hypothyroidism, the pituitary cannot produce enough TSH. So thyroid hormone falls because the thyroid is understimulated. And the TRH from the hypothalamus may rise because the hypothalamus is trying to drive the axis. Finally, in hypothalamic hypothyroidism, TRH is low, so TSH is low, and thyroid hormone is also low. So you can see how you can start to distinguish patterns about where the cause of hypothyroidism might be just by having a little bit of a look at some thyroid function tests where you measure T4 and TSH in the blood. You don't really measure TRH very often. So now I want you to think about what some of the common symptoms of hypothyroidism might actually be. So it's basically thinking about how symptoms follow physiology. So again, on the left-hand side of the table, I've shown you what happens if you've got reduced thyroid hormone. Remember, because thyroid hormone regulates metabolic rate and heat and cardiac stimulation and GI and growth and development. So we've got a decrease in all of those things. And this, you don't have to be a clinician to do this, or a doctor, or a medic, or a medical student. You should be able to work out what might happen just from understanding the physiology of what's going on in the condition itself. So press pause and think about what you think the clinical consequence might be in each case. Okay, so let's go. So if the metabolic rate has gone down, then that causes fatigue and weight gain because they're not burning as much energy. So you've got less energy and you start to put on weight. What about heat? Well, your metabolic rate has dropped, so you get reduced heat production, and that starts to lead to cold intolerance. You get a reduced cardiac stimulation, so therefore your heart rate slows, so that's bradycardia. And you might get reduced GI motility, and so therefore you might get constipation. So those are some classic things that you might get, but as well as that, you get decreased growth, decreased CNS development. So you might get growth impairment. So you're thinking in early stage, so in fetal development or in very early infancy, then those. Other symptoms include things like myxedema. So this is quite a useful clinical sign. It is not just simple fluid overload. It actually reflects the accumulation of glycosaminoglycans because of their reduced degradation, because of a reduced metabolic rate in connective tissues. And these molecules attract water and therefore produce what's called a non-pitting edema or swelling. So you can see the swelling in the legs in that patient on the right-hand side. But also, a goitre may occur in primary hypothyroidism due to chronic TSH stimulation. So if the thyroid gland isn't functioning properly for whatever reason, for example, we'll come to it in a second actually, but iodine deficiency, the gland cannot make the thyroxine, but it's being continuously stimulated by TSH, so it may become larger, and that's a goiter. So what is the most common cause of hypothyroidism? Well, in developed countries, it's Hashimoto's thyroiditis. And so this is the classic autoimmune cause of hypothyroidism. This is where your immune system targets the thyroid tissue, and that leads to chronic inflammation and progressive follicular destruction. So the follicular cells, remember, those are the cells that make up a large part of the thyroid gland itself, and are the building blocks. They are the cells that are making the thyroid hormone. And so in autoimmune thyroiditis, which remember is inflammation of the thyroid gland itself, you know, the anti-thyroid peroxidase antibodies are also a very important kind of diagnostic feature, because thyroid peroxidase is an enzyme required for thyroid hormone synthesis. And if the immune system is targeting this thyroid peroxidase, or TPO as it's also known, that tells us that thyroid autoimmunity is present. Another molecule within the thyroid gland is thyroglobulin. And if you see anti-thyroglobulin antibodies, they're targeting that thyroglobulin protein structure. So that's a large protein scaffold inside the thyroid follicles. And that thyroglobulin is where the iodinated tyrosine residues are stored and coupled to form both your T3 and your T4. So like I said, both of these antibodies, in particular the anti-TPO, thyroid peroxidase, are useful diagnostic markers. But it's key with this, the thyroid hypothyroidism actually mainly develops because of autoimmune inflammation of the thyroid gland, and that damages that thyroid tissue progressively over a prolonged period, which goes on to lead to that thyroid destruction, obviously. And as you might expect, in most cases of hypothyroidism, they're treated with synthetic thyroxine, so your levothyroxine. Just worth mentioning here is iodine deficiency, because it's very prevalent in developing countries. And in this case, the gland lacks the iodine substrate needed to make your T3 and your T4. In developed countries, Western countries, iodine is often supplemented in table salts, in cereals and other products, which means that iodine deficiency isn't really very common in Western countries. Another cause of hypothyroidism, which is actually a very important one, is congenital hypothyroidism. And this is important because thyroid hormone is essential for normal growth and brain development, in particular early in life. It affects about 1 in 2,000 live births, and there are multiple reasons. It could be down to thyroid dysgenesis, where the thyroid gland isn't developed properly. The thyroid gland may be absent, rather. It may be ectopic, underdeveloped, or may not be able to produce the hormones itself. But the key point is that there is a growth impairment, or those, if it's allowed to progress and not detected early on, it can lead to growth impairment, deafness, thick tongue and neck. There are some classic features that are obvious. And so what is done in a lot of countries is they take a blood spot at birth. This is put onto what's called a Guthrie card, and then you can use those blood spots on that Guthrie card to measure a variety of molecules that are present within that blood. And in the case of looking for congenital hypothyroidism, they're looking for TSH, or thyroid stimulating hormone. And so, as you might expect, if there is thyroid dysgenesis and these newborns aren't able to produce thyroxine, or thyroid hormone, so T4 and T3, this means there isn't any negative feedback going back to the anterior pituitary. So if you look at the image on the right-hand side, there's a lack of negative feedback. So TSH levels continue to rise, trying to stimulate that thyroid hormone synthesis, but the gland isn't able to make it. So the TSH keeps going up and up and up. So therefore, in congenital hypothyroidism, if there's a raised TSH, you would be very suspicious of congenital hypothyroidism at birth. And of course, as you may expect, the treatment is with levothyroxine, because this replaces the missing T4, and the peripheral tissues can then convert that T4 to T3. Key thing, as I've just said, early detection and prompt treatment allow most children to have good outcomes, and that helps to prevent that permanent neurodevelopment impairment that can develop otherwise. So, I've given you one of the answers. How annoying of myself. So I want you to think now we're on to hyperthyroidism. So we're moving away from hypothyroidism. Most of the symptoms of hyperthyroidism are related to increased oxygen consumption, utilization of the metabolic fuels that we've just talked about, carbs, fats, and proteins, and sympathetic nervous system activity. So just like what we've just covered for hypothyroidism, I want you to think about what the clinical consequence might be of changes. And so we can see in this one, I've already given you one answer, did that on purpose, honest. If you have an increase in central nervous system activity, that can lead to nervousness, irritability, and fine muscle tremors. So there are some of the classic symptoms that patients may have. So again, press pause and have a think about what the other symptoms or the other clinical consequence that patients may have. Again, linking physiology to what happens in the body. Okay, so should be nice and easy. So if there's an elevated metabolic rate because you've got too much thyroxine, obviously that can lead to weight loss, often despite an increase in appetite. That you'll get an increase in heat production, of course, because you're breaking more fuel down. So that can cause an increase in heat production and heat intolerance, but also an increase in sweating as well because of sympathetic responsiveness. So that sympathetic nervous system giving those heart palpitations, giving those muscle tremors, giving that sweating effect. You get cardiac stimulation, which of course can lead to tachycardia, linking in to the palpitations as well. So an increase in your heart rate, and GI motility increases, so that can go on and lead to diarrhea. Well, what are the most common causes of hyperthyroidism? Well, Graves' disease is the most common cause. And this is where you're getting, just like in Hashimoto's, you remember it was autoimmune, but it was autoimmune thyroiditis. So you get inflammation and gradual destruction of the thyroid gland. In this case, you're getting autoimmune production of thyroid stimulating antibodies or immunoglobulins, and those antibodies activate the TSH receptor. So you've got a thyroid stimulating antibody, comes in, binds to the receptor, stimulates the thyroid gland, producing thyroid hormones. The thyroid hormones has negative feedback on the anterior pituitary, so the levels of TSH are reduced, even though the thyroid hormone is being stimulated through this other mechanism. The condition may be associated with a diffuse goitre, thyroid eye disease, and that includes exophthalmos, so bulging eyes, and lid retraction as well. So how do you treat this? Well, I have a little bit of a think about what you might want to do. You don't have to be, like I said, a medical student or a doctor to be understanding these, but you want to switch off that thyroxine or that thyroid hormone production. So what might you do? You might try and give drugs that reduce the release of thyroid hormone from the thyroid gland itself. So things like carbimazole. You might want to, if that doesn't work, give radioactive iodine. So basically, the thyroid gland is pretty much the only tissue in the body that requires iodine. So you can give radioactive iodine. It's only the thyroid gland that takes it up, and that will destroy it. And of course, then patients would need to be given thyroxine because they'll have destroyed their own thyroid gland. And of course, finally, surgery, so a thyroidectomy, whipping out the thyroid gland. And again, that would require levothyroxine.